Good morning, Sawadika. Thank you very much to the organizers for giving me this opportunity to speak to you about WHO's guidance and recommendations for integrated service delivery in the context of HIV. The outline of my presentation is very simple. I'm going to give you a few pointers in the introduction about what we mean by ISD, why it's necessary, and then go on to talk about some of the broader considerations and recommendations when we talk about integration. Integration science is not something which is very clear, but certainly we should be aware of what some of the principles are around integration, and I'd like to discuss those with you. And finally, I will summarize and discuss some of the ways forward in terms of how we can integrate. So when we think about a patient, I would like you to think of an HIV positive woman who is pregnant, who is also somebody who has a history of using substances and uses opioid substitution therapy. Think about all the various aspects of her needs in terms of health. And let's think, do current HIV programs, does the current model of service delivery, does the current model of care help us to address the needs, the multiple needs of people living with HIV? So what is integrated service delivery? What do we mean by that? We need some sort of definition, and I propose a working definition to you. And the definition is the management and delivery of health services so that clients receive a continuum of preventive and curative services. I highlight here preventive, not just curative, but the need to offer preventive services according to their needs, not based on the convenience of our clinics, not based on the convenience of our doctors and nurses, but their needs over time. That means we have to take a life cycle approach and with the different levels of the health system. What that means is that we're not just thinking about services at the level of hospitals or tertiary care facilities, but also at the level of primary health systems and healthcare at the lowest level. What are some of the unique reasons for considering integrated service delivery in the context of HIV? I think one of the most important things is that with the increasing coverage of ART amongst people living with HIV, we've got so much increase in longevity. People are living longer and longer. And mostly what we're seeing is our population of people living with HIV who are on ART are aging. Globally, this percentage of people over the age of 50 is about 17%. But if one was to look at the figures in Thailand, for example, I would not be surprised if more than 25% of people on ART are actually over the age of 50. And as we age as a region, we will continue to see aging of people living with HIV. With aging comes the entire burden of non-communicable diseases. And in people living with HIV, we have a double burden, not just of non-communicable diseases, but also mental health. We've also seen that in our region, where most of the HIV is not generalized, people who have HIV are often people who either come from a key population, they have a background in injecting drug use or in sex work, or men who have sex with men, or maybe from the transgender communities, or maybe from their partners. So you could very easily have people living with HIV who have multiple health needs. And I give you the example of a PLHIV with TB who's also using methadone, or a transgender person living with HIV who is on hormonal treatment. Integrated service delivery enables holistic, patient-centric services. We, as a region, are pushing forward for universal health services, for universal health coverage. And the fundamental principle of universal health coverage is client convenience and making sure that we reduce out-of-pocket expenses. When we have services which are co-located, that are integrated, the first benefit is from the client's perspective, because it helps them to reduce transportation, lost earnings by having to go to multiple appointments. From the perspective of health outcomes, we also see reduced loss to follow-up, minimization of drug-drug interactions, and side effects. The other really important reason to think about integrated services is that HIV services have built up a real infrastructure and social capital over time. And it is unfair that this should not be used to support other ways of being healthy, including in terms of prevention, in terms of non-communicable diseases. So really, the utilization of this infrastructure is a very, very key consideration in terms of why integrated services should be thought about. Now, when we think about a health system perspective, we go beyond the patient, we go beyond the provider. If we look at it from a service perspective, what are the benefits of integrated service delivery? The first is that you leverage different service entry points. People can enter services in various ways. A person with TB could present at a pediatric clinic. Similarly, a person with TB could present in inpatient services when they have been diagnosed with pneumonia. The same applies for HIV. Different service entry points allow us to connect across various disease issues and not just focus on structural silos. This enables efficiencies. It enables efficiencies in terms of time, human resources, but as I mentioned earlier, also in terms of allowing patients to have more convenience and to reduce their costs. When we think about integrated services, we can also think about it from a continuum perspective, going all the way from prevention to care. And from a health system perspective, prevention is much more cost effective than just care. We have to think about how we maximize health promotion, how we maximize prevention, and take our eyes just off the disease treatment perspective, which has been very, very important in reducing morbidity. But in the future, it cannot be very sustainable if we only focus on treating with pills for ARVs or something else. We need to be thinking about PrEP. We need to be thinking about other preventive services that will become very important for HIV going forward. I already mentioned that, from a health system perspective, integrated service delivery has big gains big implications for reducing patient costs and out-of-pocket expenses, but it also supports people, supports clients with multiple health needs. So that is why, in this context, if you think about how HIV services were developed first, we had a very, very vertical approach, and this was needed because in the early years of HIV programming, you needed rapid innovation, you needed rapid response. And there were several unique aspects of people living with HIV, which had sociocultural implications, had health policy implications, and all of this led to AIDS exceptionalism. And while that was a necessity in the past, and some of that still needs to continue in the current setting in some contexts, overall, the epidemic has evolved and the response cannot be as it was 20 years ago. We have to think about HIV now as something which has to be delivered, HIV care has to be delivered as a sustainable solution within an integrated, resilient health system. So integration is not a new concept, certainly, but we need to think about what does that mean going forward. So let's think through some of the conceptual issues around integration and what have been some of the challenges when different health systems think about it. When WHO developed the Global Health Sector Strategy on HIV in 2016 to 2021, for the first time we said that it's clear that if you link HIV with other services, such as TB, with hepatitis, and other issues which are very, very important, STIs, mental health, then we're seeing reduced morbidity and mortality. And therefore, a chronic care model for HIV treatment and care offers opportunities for addressing broader health issues as well, particularly non-communicable diseases, mental health, and substance use disorders. And with that in mind, the strategy says that we really have to focus on improving the linkages with other areas, and this will have a much larger impact on the benefits that we have. But then there is no clear way of saying there is only one way of delivering integration. We have to think about different models and how integration can work best in different contexts. And it's a thematic area which is also sensitive among stakeholders. People feel that, you know, if we generalize too much and we bring in too many issues, then the focus on HIV and the push for integration may actually move away from the focus on elimination. So overall, it's important to think through some of the principles around guiding that integration. Now, according to WHO, there was in the 69th World Health Assembly, there was something which was agreed, and that is the Integrated People-Centered Health Services Framework. And as you can see, this framework that was adopted by all member states in the 69th World Health Assembly has 5 key pillars. And these key pillars are around empowering and engaging people. This is not a concept which is unfamiliar to those of us who work in HIV. We've always talked about key population-led health services. We've always talked about community engagement. But this is a concept which is relatively new in many other areas and diseases. For HIV, we understand it very well. The other pillar of this integrated people health services is strengthening governance and accountability, reorienting the model of care, coordinating services within and across sectors. And for all of this, we need an enabling environment. So this framework is calling for reforms to reorient health services where we are putting individuals, families, carers, and communities at the center. And these are supported by responsive services that better meet the needs of people, rather than focusing much more on what is convenient for the health system to deliver. As part of these 5 pillars and strategies that I mentioned earlier, there are some key strategic approaches. And because in the audience, most of you are clinicians and people who work on HIV programs, I really wanted to focus on strategy 3, which is reorienting the model of care, and also strategy 5, which is focusing on the enabling environment aspects of this. So if we go to the reorientation of the model of care, there are 5 or 6 key areas to think about. The first is, if we are going to reorient the model of care, what is very important is that there are national health policies and strategies which promote integrated people-centered health services. And we have to define service priorities based on life course needs. Obviously, the social preferences have to be thought about, but the big principle here is the model of care has to assess life course needs. The other thing about the model of care is it has to revalue promotion and prevention and public health, and not just focus on individual clinical requirements, not just the individual patient and the curative aspect, but the broader issues around health promotion, around prevention, as well as public health. It's very important to do this in the context of a local health needs assessment, and that will be needed if you're going to be thinking about responding to people at the local level through primary healthcare systems. This is also important to think through in the development of primary healthcare systems. All across the region currently, there is a big push for primary care systems. And when we're thinking about the model of care, we have to think about what care can be offered for people living with HIV and their other health needs at the primary healthcare level. We also need to be thinking about doing much more in terms of decentralization more broadly to the local levels. And this is something which in many countries is talked about, but is not being pushed forward fully. A key issue around reorienting the model of care is innovation and incorporating new technology. Specifically here, I'd like to raise the issue of shared electronic medical records as well as digital health tools. This is something which is going to be really important if we are going to be able to provide comprehensive care to individuals. The other area that I wanted to focus on was the enabling environment aspects under Strategy 5. And I think here one of the key issues is reorienting the health workforce, aligning the regulatory frameworks. Who can treat what is, for example, a really important discussion at the moment. Who can treat hepatitis in a person living with HIV? Should it be just a gastroenterologist, or could it be an infectious disease specialist? Who can treat TB? Can it only be a pulmonologist, or can it be somebody else who has broad infectious disease training? The training of health workforce to think about broad integration issues, as well as the leadership to push forward this agenda is going to be very important as well. I think while we are moving from vertical to integrated approaches, we have to understand that transition is going to be a big aspect of this planning, and change management, how we manage change while we go from vertical services, only ARV specific or treatment specific services, to broader services for PLHIV is going to be a key area to think through. So if I was to summarize, what are some of the priority practices to support the implementation of integrated people-centered health services? Then workforce capability is the first one. Training the workforce to think through integration. The second one I've already mentioned is transitional or intermediate care, as well as the entire change management aspect of this. The third important priority is continuity with a primary care professional. There has to be one primary care professional who provides some level of continuity and helps to coordinate all of the services that the person who needs, that the patient or the client needs. Co-location of services or a single point of access is another really key priority to think through. And comprehensive care along the entire life course of the patient to the client is another priority. At the moment, we are thinking about needs of aging and thinking about gerontology as a really, really important science and skill moving forward. But those are not the only areas that need consideration. Psychiatry, mental health, etc., are also really, really important. And this is important, particularly when we're thinking about case management of people with complex needs. Think about a substance using adolescent who is moving from pediatric treatment of HIV to adult treatment, as well as their sexual health needs, their emotional needs. And these sorts of issues require case management. They cannot be looked at through the lens of a vertical service program. The other really critical priority is that of technology. As I mentioned earlier, the use of digital technology, the use of virtual platforms to talk to clients, to talk to patients, to support adherence, as well as the use of digital records is going to be really, really important. And then lastly, having really clear frameworks and agreements and regulations that promote collaborative planning of care and shared decision making. So I want to now give you some examples within WHO in our different regions where some progress has been made towards integrated services. So we'll think a little bit about, what has happened in different regions of WHO. But before that, I just wanted to summarize a little bit where we were in the global health sector strategy for HIV, where we are very clear that we have to take HIV out of its isolation. HIV programs have to be linked to the broader health program, but there has to be coordination across all sectors relevant to HIV. What that means is that the specific issues of HIV are still maintained, but there is coordination across this. A key important issue is that of national health financing arrangements and how this includes HIV. In Thailand, this has been done very well. Thailand is a really good example of integration of HIV care packages into national health financing arrangements, but in many other countries, this is not the case. And HIV programs continue to be donor dependent. And unless there is coordination amongst donors, integration becomes very, very challenging. We have countries like, we have some countries where, I will not name the countries, but we have countries where we have 4 or 5 big donors and everybody is running HIV services in a very different way, providing a very different package. And this does not bode well for integration. So clarity on coordination across all of the donors, as well as the health financing arrangements, is a key issue when we're talking about integrated service delivery. So I wanted to talk a little bit about integration of HIV with sexual and reproductive health, and what are some of the common threads, common issues that are needed in order to do this. And this is based on the work that has been done by WHO, UNICEF, and UNFPA. They looked at 11 case studies of integrating HIV and sexual and reproductive health in mostly from Africa, but also some other settings. And what we saw here was that what is common across both programs in order to build the integration was sustained political commitment and coordination, clear, streamlined, documented strategies and policies. So really writing down clearly what the SOP for integration is, ensuring community engagement, making sure that everybody understands why these programs are being brought together, what is actually helpful to the community when programs are brought together, and learning from them in terms of how they can be the most effective for clients is something which was common to both. A common supply chain system is fundamental. You cannot have integration if you say, yes, as part of HIV, we will be looking at family planning needs of pregnant women, women who are not pregnant, or of postpartum women, and not be able to deliver any contraception to them. So the supply chain integration is very, very important. Integration of M&E systems is very important because otherwise you still have 2 very, very separate systems that don't talk to each other. Decentralization is key, and co-location of services as well. I wanted to also raise for you some of the broader WHO frameworks for disease elimination. In PAHO, in the Pacific, in the Pan American Health Organization, what is now being pushed forward is an integrated disease elimination framework. And this is happening for two reasons. Member states, countries are saying, we cannot keep working with disease-specific issues. We have to work in an integrated system. And while elimination has focused only on stopping transmission, really what we have to think about is the negative health effects that go beyond the transmission of diseases alone, that really thinks about how people live their lives with diseases and how these are addressed over the life course. So therefore, in this elimination framework, a broader definition of WHO's definition of health has been brought in, not just around stopping transmission, and thinking about a people-centered integrated framework with a holistic health systems perspective. So that's in PAHO. And we are also seeing a similar approach come through in the WHO TB strategy. If I share with you the NTB strategy, you can see that there are very clear areas where we're talking about preventive therapy for people at high risk. That is giving TPT, TB preventive therapy for people living with HIV, as well as collaboration of HIV and TB services and the management of comorbidities. Let's talk a little bit about NCDs now. We have very clearly seen in our region that NCDs are a really, really big issue. Diabetes has a very, very high prevalence in the Southeast Asia region. We also know that mental health issues are really central to the way in which we've been thinking about ensuring adherence as well as the well-being of people living with HIV. And that sits very clearly, mental health sits very clearly with non-communicable diseases in many countries. So we are really, really have no choice but to think about how NCDs and HIV and aging and mental health can come together. We know that HIV is also associated with increased risk of some NCDs. And we know that service integration in a chronic care model is something that is something that has been shown to be effective in low risk, in low resource settings. So the synergies that are needed around integrating this will of course extend to logistics, to supplies, to training, to supervision, as well as monitoring and evaluation, and evidence-based generation. And to look at what innovation can happen in this area is something that is critical and we're pushing for in WHO. I want to talk a little bit about the discussion paper that we have in WHO for the potential synergies and share with you some areas where HIV and NCDs can work together in the areas of prevention, diagnosis, enrollment into care, as well as disease management. So if you look at this table, you can see under HIV, what do we do in the areas of prevention? And how can we bring in awareness for NCD risk factors, as well as health promotion and risk reduction when we talk about prevention in terms of specific HIV interventions, Similarly, for testing and counseling and referral systems, contributing to diagnosis, in NCD areas, we could be talking about early detection and screening of NCD risk factors. For treatment, we could be talking about early treatment, behavior change counseling, and linking it to social support in the same way that we've pushed for early treatment for HIV, behavior change counseling, and link with community care and support. Community care and support is going to be a really, really important area for aging. And in HIV, we've done quite a lot of work to bring this together. The next area of integration I want to talk about briefly is what we call triple elimination. This is something we're pushing for in the Western Pacific region, as well as the Southeast Asia region of WHO. And we are bringing together the approaches of eliminating mother-to-child transmission of HIV, congenital syphilis, as well as hepatitis B. And this has three pillars. The three pillars is, the first one is coordinating the national policy for hepatitis B, congenital syphilis, as well as HIV, coordinated monitoring and evaluation of the elimination, as well as the seamless quality of care for women, newborns, children, and families. The next potential area where we can have integrated service delivery platforms is harm reduction. As you know, in our region, substance use has been a big issue, and we have recently come up with guidance to say that HIV and STI programs can be implemented together as part of drug dependence, mental health, as well as hepatitis programming. So seamless services that range from HIV, hepatitis, STIs, TB, family planning, mental health, and drug dependence treatment can actually be offered on a harm reduction platform. And a single window of services which bring in an enabling environment approach that respects the rights and dignity of people who use drugs is really fundamental to being able to provide these services. We also have similar guidance in WHO for integrated services of sex workers, men who have sex with men, as well as transgender persons. Now, diagnostic innovations and opportunities also are very, very helpful at the moment in terms of being able to integrate. We've seen lots of point-of-care tests that allow multi-disease platforms for diagnosis of HIV, STIs, TB, hepatitis C, and HBV. We've seen that in the Gene Expert platforms. We've seen that there are self-testing approaches now which allow integration as well. We are talking about self-testing for hepatitis C as well as HIV. We have dual test kits for HIV and syphilis now, which can be used across programs. And we also have the use of dry blood spots, which allow us to now look at hepatitis B, C, and HIV, and look at really ensuring early diagnosis as well as integrated diagnosis for across diseases. So I'm just going to summarize now and talk about some of the challenges that you might see in implementing this, and think through the issues around how this might be addressed going forward. The first thing is that integrated service delivery at the moment has very unclear expectations, and there are some apprehensions around this. So making sure that the expectations are clarified is fundamental. And secondly, we have to think through the infrastructure issues. Do we have to have specific changes to infrastructure? Is there adequate infrastructure? Is the infrastructure for bringing together a model of care which just supports integrated services available? We need to be thinking about having discussions proactively around infrastructure design and engage with health systems to think about this. The other issue is that of financial and human resource constraints. At the moment, the funding is sitting very clearly with HIV, but there isn't a lot of funding for non-communicable diseases. There isn't a lot of funding for hepatitis. And where there are donor-driven services, it becomes important to think about how donors think about integrated service delivery. The other issues to think about are our human resources adequately trained? Is there enough discussion to really bring together training materials and modules to support integration? A key issue is that of HIV-related stigma and discrimination. Many services say, please don't integrate us with HIV because there is too much stigma. We don't want to stigmatize people even further by integrating them with HIV services. But the fact of the matter is that there are many diseases that are stigmatized: mental health, TB, as well as HIV. And what we need is an integrated approach to addressing stigma across all these areas. And finally, a key challenge in integrated service delivery that we need to think about is how do we ensure community participation across all areas, not just from HIV, but from hepatitis B, but from TB, but from mental health and non-communicable diseases. So what are the ways forward? I think we need to take a very practical approach to integrated service delivery. WHO has provided some guidance, but it's important that in every context we think about progressive integration, which emphasizes priorities for that location, for that country early on. We need low-hanging fruit to be addressed. For example, identifying and assessing depression as well as nutrition is something that we could be doing in HIV services, in TB services, in STI services. It is something which is not it is something which can be done relatively early on, and this can really impact treatment outcomes. Nutrition is really important for both HIV and TB services. There is no reason for this to be done separately. Depression is a key issue for people living with HIV, but also we see mental health issues and suicides in TB. This is something that should be done very early on. Another key area where we have low-hanging fruit is the digital health records. We are living in a time where there is really a huge potential for digital health, and sharing records is an important area. As long as confidentiality is maintained, as long as patient confidentiality and privacy is protected, digital shared records is a way to go. Another really important area when we push forward for integration is engaging communities in planning and implementing ISD, as well as making sure that all healthcare providers are able to listen to communities. Integration is not a cure for inadequate resources. In some countries, everything is being bunched together without adequate resources, and we do need to be clear about making sure that money is available for integration. Implementation research is key to promote integration science. We do not know about the best ways forward for integration in every setting. That will be different in each location. Finally, integration does not mean that everything has to be integrated in one go into one package. In reality, there are many different possible permutations, and it is for each country, each location to think about what would be the best ways forward. So with that, I'd like to thank you very much for your attention and once more make a plea that integration is important, but how we do it will be really, really different in different contexts. A lot of thinking and assessment is needed, community engagement is needed, but there is no option to move out of AIDS exceptionalism. Thank you very much for listening, and happy to take any questions.